As folks are able to take their seats, we got a late start due to a closed session that ran over a bit. If you see a lost council member or supervisor, please guide them our direction.
For whatever it was worth, I didn't say a word.
Welcome, everyone. We'll begin our joint meeting with the county board and county staff. We're really grateful for our county partners taking the time to come here to City Hall to talk about mental health and homelessness, two issues of great concern, I know, to everybody here. I wanted to hand the microphone off to President Simidian, who I believe will be introducing the key members of the county team who will be leading us through this first section on mental health. President Simidian.
Thank you very much, Mr. Mayor. Before we do that, if I might ask that we call the roll and establish the presence of a quorum. That's the custom and practice at our board, and we appreciate your accommodating that.
Councilmember Davis, Nguyen, Jones, Wasserman, Camus, Yeager, Carrasco,
here,
Licardo,
Present.
Simidian,
Here.
Chavez,
here,
Rocha, Cortese, Perales,
Here.
Dieppe,
Present.
Jimenez, Arenas. We have a quorum.
Thank you very much, Mr. Mayor. And let me just turn to our county staff, or at least the board-appointed members of our county staff. Dr. Jeff Smith is our county executive, and seated next to Dr. Smith is our county counsel, James Williams, and our clerk of the board, Megan Doyle, is right over here. And I think what I should do is ask you, Dr. Smith, to introduce the members of your team who are here, who may be participating in the conversation today.
We have our Chief Operating Officer, Miguel Marquez, sitting over there. Today you'll hear from Tony Tullis, who's our Director of Behavioral Health, and Key Lee, who's the Director of the Office of Supportive Housing. And I think that's it, other than the people you've already introduced.
Thank you very much, Mr. Mayor. I think those are most of the key players. I'm sure there'll be somebody we fail to introduce, but let me pass back to you.
Thank you, and I'll just ask our City Manager Dave Sykes to make some brief introductions here, and then we'll get rolling. Dave.
Sure. Joining us here today, we have Assistant City Manager Jennifer McGuire. Also in the box over here, Lee Wilcox, my Chief of Staff. You'll also be hearing from our Police Chief Eddie Garcia and our Director of Housing, Jackie Morales-Ferrand.
Great, thank you. So we have neglected to, forgive me, my mistake, we have not yet risen for the Pledge of Allegiance, so let's do that at this time. Thank you all. As we convene, we're trying to get back on the track of convening every year because there are so many important issues that we face together. And this is really an opportunity, I think, today for many members of the council to learn quite a bit more about the county's work in behavioral health, which I have only recently been able to start to learn more about and understand better the constraints and challenges the county is dealing with as we work together on behavioral health issues that obviously impact us, whether it's around homelessness or policing. So I wanted to hand this section off, I think, as we jump into the behavioral health update to Jeff Smith, or anyone Jeff might designate, to lead us through.
Thank you, Mr. Mayor. Tony Tullis is going to start with a couple of relatively brief PowerPoints so we can describe what the county is doing and some issues that are of particular interest to the City Council and the Board of Supervisors. And then we'll hear from Keely. So, Tony, you want to start?
Good morning. Oh, you have to lean in. Let's wait. Oh, just like that's okay. Sorry. Good morning. I'm Tony Tullis, the Behavioral Health Director, and I'm really excited today to share information about our system. The plan is to provide you with a broad overview of what we do in behavioral health and the continuum of services that we provide. I'm going to be highlighting what's going on right now with our current crisis services and our new crisis services, as I know that those are particularly important to you as council members and certainly to our Board of Supervisors. In addition, I'll be highlighting some new programs that will be supporting the people we serve as well as the broader community. I would like to say as an opening comment that Keely and I, because I think we want to explain this to you, our partnership is very, very solid because all of the services that you'll hear about today, both from me related to housing and what Key shares, are being provided by behavioral health. So all of the clinical services are provided by us in partnership, and they're housed with the Office of Supportive Housing. So we work really closely together on that. I have a second PowerPoint as well today on assisted outpatient treatment, also known as Laura's Law. And what I thought I would do is start with an overview. I know Chief Garcia will make some comments as well, answer any questions, and then go into the second PowerPoint. Okay? So do I click it myself? Here we go. Just click onto mine, this one over here. Okay, so first of all, what's important to understand about behavioral health is we're actually a Medi-Cal managed care plan, just like Anthem, just like Family Health Plan. We have all of the same regulations. It's a heavily regulated environment, and we actually have a health plan for two different areas, all of the specialty mental health services as well as our substance use treatment services. We're a really large organization. We're the largest plan in the Bay Area and the sixth largest plan in the county, in the state. And I think what's important to explain is that every county has to follow a particular regulation, and with that come particular services, particular population that we need to care for, and a big focus right now on network adequacy to be able to meet the needs of people. We serve over 35,000 people a year, and that's across the lifespan, from 0 to 5 little bitty kids where we're doing prevention all the way up to older adults. And I think it's important to note that we're seeing more and more people, so we expect in this fiscal year that our numbers will be even higher in terms of the number of people we serve.
Before you go on, Ms. Tullis, I was going to say through the chair, excuse the interruption, but for council members who are not working in this field on a regular basis, the very first bullet point is worth spending a moment on, because we call it behavioral health, but historically people have thought about mental health as one set of issues and substance use disorders as another set of issues. And so this very first bullet, which it's easy to just gloss right by, reflects a fairly significant shift in the way these issues are being addressed and approached, certainly by our county. The reason you hear the phrase behavioral health is because it blends those two sets of issues into a single focus, behavioral health. And that is no small challenge in terms of recasting what we do at the county. But in terms of your experience out in the community, I just think it may be helpful and important to be mindful of the fact that mental health, serious mental health issues and substance use disorders are blended in the same organization in our county work.
Yes.
Forgive the interruption.
No, thank you, Supervisor. Next. We manage two very significant integrated systems of care. One system is focused on children, youth, and families, and the other is about adults and older adults. We also have substance use treatment services, And as part of that program, we provide medication-assisted treatment and narcotic opioid treatment programs as well. We provide in the county about 30% of the services. About 70% of the services are contracted out, largely through certified behavioral health contract providers out in the community, but we also contract with many residential facilities and acute care hospitals. To give you the breadth to respond to what Supervisor Simidian noted, we have 625 different programs, different scopes of work in the department, and we manage a total of 465 contracts. So it's a very complex organization. This year in our county adopted budget, we have about 704 employees. That number's climbing, and our appropriation this year is $519 million. Next. I want to emphasize briefly prevention and early intervention. There's a great deal of research underway for mental health in particular, and we know both with substance use and with mental health, if we can do things earlier through prevention and early intervention, there's a lot of evidence that it will dramatically mitigate symptoms of mental health issues as people age, as young people age, or if we're really fortunate, be able to prevent that from happening. So these are some of our big ones. We have a suicide prevention team available to anybody and everybody, available 24/7. We receive thousands and thousands of calls here in the county. We also have launched a very significant substance use prevention program. Our latest one has been Wasted on Weed, focused on youth and marijuana. That's actually won a lot of awards, and it was designed by a group of youth. We have a substance use opioid collaborative. Members from the city participate on that. It's really how do we stop that tide. I will say in our county, opioid addiction is not the biggest drug issue. Our biggest drug issue in this county is actually methamphetamine. We have schooling services that provide supports, assessment, and treatment across the county, and I want to note that we're in 131 of San Jose schools. And then consumers, which to us are clients, and family support services. You can see that we have a number of outreach and supportive efforts to support our families, working with NAMI and all of the many clients that we serve. Next. You're very good at this. So I've got three, really, the police chief is helping me. That's great. I've got three brief continuums of care. The department is very large with many, many, many services, but I wanted to give you a quick snapshot of what we do. In all of our areas, we lead off with prevention and early intervention. We're expanding a lot of services there with our Mental Health Services Act funding. We then provide, this is the Children, Youth, and Families Continuum, a lot of outpatient services. We do have a program for 0 to 5 kids that's nationally recognized as a model. Intensive outpatient, meaning somebody that's not hospitalized but really requires a fair amount of intervention. Regulated KDA services for young children, foster kids. Full service partnerships, which are very high-end services. You'll see this in our slides. This is where you provide a lot of staffing and you provide 24/7 care for individuals living in the community. And we have those services both for children and for TAY. Transition age youth are between 16 and 25, and they're a big focus of our emerging work right now. Wraparound is the most intensive services that you can have as a child, required by the state. We're RFPing these services shortly, re-RFPing. And then we have children that are in acute hospitals and also long-term residential treatment. I do want to do a shout out to the board. Supervisor Simidian might mention this, but the board approved last week a $220 million acute behavioral health facility on the VMC campus for children, youth, and adults. It's very, very exciting. So next slide. This is our adult and older adult. This is where the bulk of our work is. It's the largest system. We serve annually right now about 9,000 people who live here in San Jose in our adult system. We also have lots of prevention and early intervention, but what you'll see in this one is significant outreach, and that's what Key and I will both be discussing. Outreach to try to connect people who need mental health services and are not engaged in mental health services, so we have a variety of teams at a variety of levels. Then we move into outpatient services, which means people can be treated in a clinic, in the home, or in the community. And you'll see that I've included supportive housing services there. So the work that the behavioral health team does for OSH is all the supportive housing services, and they fall under outpatient. Then we're adding very substantially a number of full-service partnership beds and something called assertive community treatment. FSPs are, as I described, very intense, but we're also standing up in this county, which has not had these services, an evidence-based practice called assertive community treatment, which is designed for the highest need people, very difficult to engage, very seriously mentally ill, and with appropriate staffing and housing, these individuals can remain in the community. Just to give you an idea, the cost per client in an assertive community treatment team is about $45,000 a year because it's a full wrap service, and I think it'll really make a difference here in Santa Clara. We also have subacute services. Many of our folks that are not able to be in the community live in residential or subacute settings, and they'll probably be there for life, so we manage all of those settings and placements. Residential services in residential care homes, also receiving services from behavioral health, crisis services, which I'm going to describe in detail, and then our acute inpatient hospitals. The last one is our substance use disorders continuum. I want to emphasize that we were one of the first counties out of the gate to put this in place, and we've become the lead for policies and practices in California. Very, very strong substance use team. So again, we're funded to do some prevention and early intervention, and up until this last year, almost all of these services were covered by federal grant and actually the generosity of the board, providing general fund to these services for a long period of time. We've been able to expand our services now. We have many more treatment services available. We're moving into partial hospitalization and intensive outpatient. And what this means to all of you is in the past, the individuals that have had drug issues, you may have dropped them off at EPS, or they may be recurring in law enforcement, may know them well. But with the expansion of these services, we think we'll be able to catch people and get them into services rather than have them on the streets or have them in and out of the hospital or jail. We're also standing up, we hope in the next year, a medical detox. So this would be for individuals that don't meet the criteria in our emergency psych unit, but really need a place to go. And we're working with our health system on that one. So that's very quick. And here's a lot. I know you're very interested in crisis, so I wanted to highlight this. We've had a suicide crisis hotline for a very long period of time, 24/7. We have a mental health urgent care center that currently works 7 days a week from early morning until 10 o'clock. Chief Garcia and I and the other police chiefs have talked about the need for a 24/7 drop-in, and we're hoping to get that up and running in the next year. EPS, Emergency Psych, is a county designated, it's the only county designated 5150 facility in the county. And those
Excuse
services.
the interruption,
Yeah.
and 5150 again is?
Involuntary. I think many of these members know. This is for the involuntary. Somebody gets picked up, they're put on a 5150 hold, they're taken to EPS for a 72-hour involuntary hold, and if their psychiatric needs are extensive, they'll be admitted to the hospital for a 14-day hold. Thank you, Supervisor. What I want to highlight here is we partner very, very closely with EPS, but that is a Valley Medical Center program. We also have on the children's side a mobile crisis program and what we call a crisis stabilization unit. It's a little mini EPS, and this program, which is housed in Campbell by one of our contract providers, can receive kids and youth that are on 5150s as well. In the last year, we've been able to stand up adult crisis stabilization unit, 8 beds here in San Jose. That's voluntary, but it also relieves the pressure at EPS and provides yet another program to support people in crisis. We have 2 adult crisis residential programs, 15 beds, one here in San Jose that's just as adjacent to our crisis stabilization unit. And the other thing that we recently were able to implement is the Sobering Center, which has been open for just a year. And in that last year, we've treated 220 individuals, about 18 people come in a month. And I think what's important on the Sobering Center is this is a place where people can come who are basically inebriated and need a safe place to go. But we're connecting the dots for individuals that arrive in the Sobering Center with a team to connect them to services. We'd like to see them not returning to the Sobering Center. And next step, the new services. We've been able to hire 8 staff. We need 12 for our mobile crisis response teams. And I want to mention that we started in January. In September, we've served 257 individuals. Of those individuals, 140 were individuals where we were working with San Jose PD. And of the total of 257, only 21 of those individuals went into jail and all of the rest went into services. So that's a big shift having the teams. In addition, our county sheriff as well as Chief Garcia asked us if we would train staff as hostage negotiators. So we trained 3 last month, and we will train additional staff as hostage negotiators. So when there's an incident in San Jose, we have trained people to help. We've been helping, as Chief Garcia will share, but now they are certified. Our staffing issue is a staffing issue across the Bay Area and across the state in terms of clinicians. The county has done 2 pretty extraordinary things. One is our contract providers have been unable to hire clinicians, and since they provide about 65-70% of our services, their inability to hire has really had an impact on our service capacity. So the board agreed to increasing significantly the rates for the providers, and they've all received rates, and we're really optimistic that they'll be able to hire staff, and that will really help us with our service adequacy. The other thing is that the HR department has created a special recruitment for mobile crisis clinicians, and it's been successful. We're interviewing 8 people this week who are really interested in mobile crisis, so we're very hopeful. The other thing that's coming in place is a countywide crisis text line, which is free and available to anybody in the county. We know historically that largely youth use the crisis text line. It will be implemented with a big splash with public information in November. We're also getting ready to stand up psychiatric emergency response teams. These are teams where a law enforcement officer partners with one of our clinicians. They actually buddy up. And the recruitment is also underway for these clinicians. Chief Garcia and his team have worked very closely with me and my team. One team will be housed here in San Jose, and we're hoping to implement in early 2019. And then the other, not crisis, but very much related, is we're standing up in-home outreach teams. And this is part of a series of outreach efforts. These teams will be supporting those individuals that wind up in EPS frequently, aren't connected to services but need to be, and we are going to be leading with a county team and then 4 other community teams across the county. Our county team will be here in San Jose, and we'll be working really closely with EPS and custody and assisting people as they get out of those environments. And that will be implemented. Recruitment's underway in early 19. I think that's it. One more slide and I'm done. And then what's ahead, we're standing up the programs that I've described already, doing RFPs this year. And I think the other thing to share with you is the demand for substance use has increased exponentially this year. So we are RFPing for 220 additional slots, which will serve almost 900 people a year, and creating more intensive slots. So overall, with these new services, we'll be able to treat more than 1,000 people in the coming year with substance use issues. So that's a very brief overview of a very big system, and I'm here to answer any questions you may have.
Thank you very much, Ms. Tullis. A lot of information conveyed in a short period of time. Appreciate that very much. We have a lot more to go. I know I wanted to open up briefly for questions and ask all my colleagues if they might consider being as succinct as possible, because I know there's a lot more to come. Chief, I believe you were going to present next. Is that right? Or did you want to?
I was just going to provide some comments, Mayor.
Okay, perhaps we'll go to your comments and then we'll come right back.
Okay, I'll try to keep mine brief. First of all, Mayor, as we know, probably we've been, one of our biggest things from the San Jose Police Department perspective is dealing with our mentally ill population and recognizing that, the first time someone's in crisis, it shouldn't be a first contact with PD. And so, when we're dealing with those mentally ill as well as 5150s, which again, for the definition is people that are danger to themselves, danger to others, or gravely disabled. And that definition comes into play a little bit later. But I can't stress enough the great partnership that we've built with Tony and her staff with moving forward. We had meetings early last year about how we can get some additional help. And right now with her teams, I know staffing is an issue for her, as it is for all of us. But I can tell you a few months ago, I heard from my staff that they helped us get out of a situation where we could have been in an officer-involved shooting. And so when I say that this system does work and this program does work on the front end, which is where we need our help. One of the things where we need help, we have we've mandated that every police officer is going to be CIT trained. And, even with the fact that even with the grand jury report that came up on the police department, there was 2 recommendations that they requested of us out of all the recommendations they did. One of them we're going to comply with. The other one just had to do with the large group of classes that they wanted to reduce, but which is a little bit difficult with regards to the fact that we're trying to train up the whole department. But even with that, we need additional help and resources. And the staff's been responding very well with our officers out in the field for critical types of situations. I'll say one of the questions that we need to, one of the things that we need to address, and the system isn't perfect, but again, these things are built on relationships. And I tell you that whenever there is a problem, I know we just pick up a phone and call each other and talk it through. And that's been very refreshing. I'll say that on the back end is an area that I think, and as I got into this, and trying to figure it out, this whole the mental health world is really like describing how a watch works. There's a lot of moving pieces. And one of the things, that we see also is the repeat people that our officers do have to take in for a 72-hour hold. We've taken over since 2012, we've taken thousands for that are repeat. Matter of fact, there were 71 individuals since 2012 that have been taken to EPS at least 10 times, if not more. And so the back end services is something that I think we all are interested in working on, keeping in mind that there's a lot of forces outside the city and the county, quite frankly, that people need to, and organizations and units need to abide by as well. But I can tell you, Mayor, we're on the right track. We're moving forward. I think the bandwidth will get better. I think the ultimate goal is, I've said this before, but there was a period of time here that we didn't have ambulances driving around 24/7 because people were physically injured. And I think the same thing goes for our mentally ill. I think we need to have that type of mentality that we need to have that help and expertise there. And then finally, Mayor, I'll say one of the issues that really gets us a little bit, and Tony and I have talked about it, and we both don't necessarily have the answer to it, although there are some things that could help, is really the individual that officers encounter out in the street that doesn't meet the 5150 criteria, but this is what our officers are seeing every day on the street, is the individual that's screaming at someone in the middle of the street, that's screaming at cars, that's screaming at people at restaurants or what have you. When we get those calls, my officers have to deal with more violent issues and things to deal with. And I understand and I know that, we need to keep our community safe, and so our officers respond. But the question we always have is, what do we do when we get there? Our officers certainly don't want to try to figure out some reason to take someone into custody if they don't need to be. That's not our role. And so we need to work closer together and try to find some, with your help, all of your help as well, to try to find some other options. So when that scenario occurs, which is what scenario that occurs actually most often, is it gives us some resources so that we can, one, keep our community safe and give it individual services. And sometimes those individuals don't even know they need services. And I know I wanted us to keep it as succinct as possible, but I can tell you things are moving in the right direction.
Great. Thanks, Chief. And thanks again, Ms. Stoyce. Okay, so several folks indicated they'd like to speak, but I think these names correspond with the council members who sat in those seats previously. So I have Councilmember Jones, but I think that's now, is it Councilmember Nguyen?
Yes, he's impersonating Councilmember
Okay,
Jones.
very well. Do your best.
That's probably the best way to get the meeting started. First of all, I have one quick comment and one very quick question. I would appreciate this meeting because this is close to my 4th year working here, but I've been begging for this sort of thing because apparently we both serve the same community, same residents. And I must admit, out of time of frustration because of my District 7, after District 3, but we have the more serious problem of homeless, especially of the mental health problem. Then I feel lost in terms of reaching out for help. So this sort of meeting, I think, is so important and helpful. I would like to ask maybe staff and both to do more. I think we should have this conversation more. Now, my question probably, it involves a lot of issues, but it boils down to one. Out of my dealing with the homeless people in District 7 a lot because of the creek, because of the jungle, so on and so forth. I must share you the reality is very sad when we deal with them on a daily basis. Out of many hundreds of thousands, very few percentage are able or willing to be helped. The large majority all fall into this, either mental health or addictions. And my frustration is I don't have the knowledge or the access or the resource to contact looking for help other than call 911, right? And even my constituents very frustrated because call 911 unless you are murdered, killed, something. If homeless, we don't have staff to respond. So I think the question is, how do we address the issue of these people, homeless, in terms of mental health and addiction that are prevalent throughout the district, the county, and are they the subject of your services? I leave for you for answer, but then very quick. Give us a kind of a broad stroke of how we approach it. But before we do that, my last comment is, out of all this presentation, we appreciate, and I think for me, for us to understand more, I would like more numbers. For example, your slide on resident services, we don't know how many there are and how would in the past and future. So maybe future meeting, we would like that data to be provided. So at least we know we have an identification of where we are and what we're looking at. So let me go back to that. The question is, how do we assess such issues of these people or our clients are actually on the street and we haven't seen any direct connection between them being there and the service available to service them?
Sir, I think that what we've been describing are programs and services and outreach to address the very needs that you have addressed. And I think one of the things we'll hear from Key about the housing outreach would be really helpful for you to know. The other thing that I'm already thinking of when you ask about numbers, perhaps our team, we've been working closely with the city, could provide you with all of the specific call numbers if you have a constituent in your district or hear about a problem and you're not sure where to go. We could provide you with that information so you could talk to somebody immediately.
Perhaps I'll jump in here. The third presentation is on homeless outreach. Is that right?
So that's
okay.
what
I'm sorry. I should have perhaps suggested we put a pause on it and we'll come back with much more information on that issue. Okay. I've Councilmember Camus, but that may be played by Supervisor Wasserman. No? It's really Councilmember Camus. Okay. Here we go.
We look a lot alike. So I thank you for that, for the overall description. I know that in the past, look, I know that the county has been releasing, the state has been releasing tens of thousands of prisoners. A lot of them probably still have drug addiction issues and are becoming homeless on our streets and mental issues. And so while your presentation is increasingly optimistic, and I think that the fact that we have our supervisors looking at building new facilities to house mentally ill people, I am still concerned that there's too many mentally ill people on our streets and less than enough is being done about it now. I know that many counties in the state have implemented Laura's Law, and you did briefly say you were going to talk about it, but then you didn't.
Why don't we put a hold on it? I realize I made a mistake, and I think there's a lot more information coming, and perhaps we should give county staff an opportunity to present all that information. Right. And then we have a lot of very good questions that need to be answered. So
And I'll hold my comment then.
Yeah, thank you, Councilmember. Perhaps we'll do that, and then we'll come back to the council. So, Ms. Tullis, would you like to take it away?
Right, why don't I provide, and this is just an overview of assisted outpatient treatment, also known as Laura's Law. Here we go. So this is just the factual information about AOT, so everybody's on the same page and knows how this works. It's court-involved intensive outpatient services for adults with SMI, serious mental illness, who are experiencing repeated crisis events and are not engaging in services on any kind of voluntary basis. It is written in the California Welfare and Institutions Code. It's very specific about the eligibility criteria and the process. AOT is really designed to interrupt the repetitive cycle of hospitalization, incarceration, and homelessness for people with SMI, and as I've said, who've been unable or unwilling to go into services. Are you my clicker? Click. Here we go. So the referral, and then I think you missed one, Chief. Go back one, yeah. So we know that there's a subgroup of adults with serious mental illness who don't engage in needed services. Some of them don't have an awareness, which the chief has mentioned and we've mentioned, that they're ill. They don't recognize they need treatment. Some may have had just a life of a lot of trauma and stigma, and they don't want services. They really push back from services. And others just have difficulty accessing or navigating our system. So sometimes there are limited options for individuals who are not voluntarily engaging in services and experience these repetitive crisis events and hospitalizations. Next. So this is a brief map of the AOT process, and this is based on the legislation specifically. So you'll see that the referral and investigation, it could be any qualified requester, which is there on the bottom part of the slide. Again, this comes from the legislation, who can refer an individual to AOT. The county conducts an investigation to determine if the person meets the criteria. And if that's the case, if they meet the eligibility criteria, the mental health director, my designee, has to certify that all of the criteria are met. And then county council files a petition with the superior courts, and the person is assigned to a public defender. The next step would be a civil court hearing, and in that hearing, if the person accepts mental health services during the first hearing, they enter into a voluntary settlement agreement with the courts, and if they do not, the judge can determine that the criteria are met, and the person receives an AOT court order. The court then orders the services in consultation with my role or my designee that are deemed to be available and been offered and refused on a voluntary basis. Now, one of the things that there are two elements of AOT that I want to share. I think it's really critical. One is that this is a legal process, and as such, it means that people will maybe wind up in services against their will. It's a civil issue, civil rights issue. But I think the other thing that's misunderstood, and it's really critical that you all understand, this process does not require medications. It does not. So it is not in the legislation. So if somebody is encouraged to participate and they volunteer to take medications, that's what we are trying to do in our regular outpatient system. But medication is not required, and I think it's really important for elected officials to understand that. Next one. The required partners are the county behavioral health department, superior court, public defender, county council, and then these individuals would go into one of our high needs services. And other partners would be referring agencies or community-based providers. And next, the implementation requires that the Board of Supervisors pass a resolution adopting AB 1421 and issue a finding that no voluntary mental health program serving children or adults can be reduced as a result of the implementation. Any of the funding that supports mental health can pay for services, And the Mental Health Services Act can cover some costs, but we cannot use Mental Health Services Act funding for anything associated with the court. And the presence, access and referral, the presence of AOT provides a mechanism for family members and other concerned parties to refer an individual for mental health services and accountability for county agencies to follow up if this is approved. And the majority of people referred to AOT do not end up in court supervised treatment and accept services on a voluntary basis. And counties are, all of the counties, many of the counties that either have approved and are using AOT or like our county standing up assertive community treatment, the ACT program is very much like AOT in that we're working with really high needs people and doing a lot of outreach and engagement to get them involved in services. And so that's repetitive, the second bullet. So most of the counties are paying for this using a combination of Medi-Cal and some MHSA funds. We can't, as I said, use MHSA for any of the legal costs associated with AOT, and counties do things differently in each county related to the cost of the county council, public defender, and the superior courts. That's what it looks like.
Great, thank you, Director Tullis. Now, I know that there are questions about this as well as what's going to come next, so why don't we keep going, and then we'll get through the presentation and come back. Questions?
Okay. I'll do my own. Thanks.
Welcome, Keith.
Good morning, everyone. Keeley, Director, Office of Supportive Housing. I'm here with Jackie Morales-Frand, and she and I and Tony will provide a little bit of an overview on outreach services and mental health services for homeless persons. Our goal here is to provide a little bit of an overview of the intersection between both services. I think a part of our day job is to try to expand and improve not just the outreach and engagement services, but how to really knit together the systems on an ongoing basis. Because when you're talking about homeless individuals who are on the streets or in shelters with various disabling conditions, ultimately the effectiveness of any type of outreach and engagement plan relies on the availability and access to a permanent housing resource or plan, and some interim housing steps along the way, plus the ability to provide ongoing supportive services. I would like to acknowledge what I think many council members and what Tony alluded to, which is there's a high level of need for behavioral health services among homeless persons. Since November of 2015, we have assessed over 15,000 persons. About 43% of those individuals have expressed that they have some type of psychiatric or emotional condition that has contributed to their homelessness, and about 40% have a substance use or alcohol issue of some sort. And that's why I think what Tony mentioned in the beginning, that the partnership between behavioral health and the Office of Supportive Housing is very critical because of the overlapping needs. Now, as kind of Tony mentioned, the behavioral health system is a very robust system, very complex system, but it, at its core, for the mental health side, it's a specialty mental health system. That means you have to have a serious mental illness, meets medical necessity, and you have to be on Medi-Cal. When we're talking about homeless individuals, even though many of them have a mental health condition of some sort, it may not rise to the level of specialty mental health services. Therefore, they're not qualified for the specialty mental health program. Therefore, we have to figure out how to deliver the service on an ongoing basis, whether that's through the specialty mental health system or through our Valley Medical Centers, if they have Medi-Cal, and for mild and moderate services. Additionally, to the level of need, we have to look at the eligibility for services, and the funding source matters a lot. Even if you have a serious mental illness, If, for example, you have Kaiser, the county is the payer of last resort, and we rely on Kaiser to provide all those services. If you are an honorably discharged veteran who becomes homeless and you're receiving your services through the VA, we rely on the VA to provide those services, and we have to coordinate with the VA. On the street, when we're doing outreach and engagement, the kind of complexity of need and can hinder our ability to engage individuals. And what I mean by this is if, for example, someone is receiving all the services from the VA, the county teams or the city teams may not have access to the VA healthcare information. They may not have access to the VA's clinical teams. They may not even know that this person is already engaged with the VA. And when we talk about outreaching to and engaging individuals of high need, the more you know, the more you're compelled to act, and the more you're able to act. The more we know about a person, the more resources we're able to leverage. So on the street or in shelters, it's incumbent upon the outreach teams and, of course, the system partners to kind of try to coordinate and rationalize all those services. And then the third point about location and access points, of course, when we think about outreach to homeless individuals, we're thinking about, or many people are thinking about, the 5,200 persons who are unsheltered on any given night. Of course, those individuals don't necessarily stay in one place. They access services through our general assistance office. They may come through our collaborative courts. They may access shelter services, and we have to coordinate and knit together the services at those points as well. And as Tony mentioned earlier, the specialty mental health services even are really about require individual consent and choice, and there are legal limitations about when we can compel those services. I think Jackie's going to outline some of the homeless outreach activities and the city's outreach teams.
Thank you, Key. So the city really started homeless outreach teams, I want to say like 5 years ago, and we had a surplus of ESG funding. And we're focusing on outreach. These are our mobile services that we provide to our homeless residents, and they're offered both by the city and the county. And there are 5 primary uses, or why we're doing homeless outreach. And the primary goal is to engage our homeless residents and to offer services such as providing emergency shelter options, providing basic needs support, and more importantly, we also conduct the housing survey, which places the individual into the housing queue and ultimately matches them up with a housing solution. And so, as Kia said, ending homelessness for us means putting someone back into a housing situation. Secondly, the outreach teams respond to our resident concerns that come through our homeless concerns hotline and email for the city of San Jose. In San Jose, we received last year 5,100 calls on the hotline requesting services and support from our residents. In San Jose specifically, we also have outreach teams that reach out to encampment residents that are scheduled to be abated. We just expanded what we call the number of touches or interactions between outreach or housing staff from 3 to 4. And what the goal of the outreach team there is to inform the encampment resident that the site is going to be abated and that they should pack up his or her belongings before the abatement occurs. Each encampment resident is offered emergency shelter, and if the resident has a child, a hotel voucher is provided to remove the family immediately into a safer environment. We also offer services as well and try to do an assessment, again, to get them into the queue for housing. We also have, one of the other goals is long-term engagement, and our Path Downtown outreach team is able to do this by building relationships with the homeless residents who are living downtown. This is really key in building trust, and it also helps the homeless resident to accept additional services. As our city council saw earlier this year, this model of outreach was much more successful in exiting people into housing. We saw a much greater success rate in the Path outreach team and actually having people exit into permanent housing than our general outreach teams. And again, I think that was because they're able to build those relationships. And then finally, the county uses its outreach teams to locate homeless households who are ready to be placed into housing. So for example, we're completing Second Street Studios at the end of this year. And we have been working diligently over the last few months to qualify homeless residents so that they can get into this housing. But they could have been qualified months in advance, and they're still living out on the streets. And so as we get closer to filling up Second Street Studios, we're going to have to find people to let them know that they're ready and they can move into the apartments. And so this is one way that the outreach teams are helping to connect people into permanent housing.
And I'd just like to add on this slide that although these are activities that outreach teams or service providers perform, there are only a handful of teams dedicated specific to outreach. Some of these outreach teams may perform one or more functions, and then some programs may have a primary mission of providing medical care, for example, and then also on the side provide outreach services. And these services are provided, as one might imagine, with teams going out into the community, but we also co-locate service providers and clinicians at locations, shelters, and, for example, the Office of Reentry Services, where people come to receive services and we can provide the necessary assessments.
So the City of San Jose has 2 outreach teams. We have a citywide outreach team that Home First is implementing with 6 outreach workers, and they're the ones that are primarily responding to our hotline calls. And then we have the targeted outreach, which is being implemented by PATH, where we have 10 FTEs. And we also have a licensed clinical social worker who supervises that team. And that team is the one that has a very specific area that they're working in. So, for example, they're working in the downtown. They're also working in the creek areas. And then they also specifically work in the downtown library to provide services. So I think the benefit, again, to the PATH model is that we've been able to create consistency and more intensive connection to people that we're not able to do in the citywide team, because again, we only have 6 outreach workers, and given the number of people who are unhoused, that's a much more challenging type of work to offer those ongoing relationships.
For the county teams or contractors, we essentially have a few different programs. One is a contract partially funded by the City of Mountain View with Community Services Agency that provides many of the similar services that Jackie described up in the Mountain View area, working closely with their law enforcement agency. Second is we have a contract with Bill Wilson Center to provide general outreach, although they have a specialization in young adults. But the sort of the bulk of the county Office of Supportive Housing outreach efforts, all of those staff, by the way, are Behavioral Health Services Department staff working in conjunction with us. The bulk of the county's outreach effort is around case finding in support of permanent supportive housing programs. And this has evolved over time. When I started, we have the ability to serve 80 chronically homeless people. The county and the city jointly funded those programs. And we relied on those individual service providers to both do the case management and do the case finding. Here's a referral, go find these individuals. Now that we've expanded and directly manage about 1,300 a budget or capacity for about 1,300 households. We're actively leasing up, say, 134 units or more of permanent supportive housing. It's become clear that there needs to be a specific outreach and engagement function related to permanent supportive housing. And right now, for our rapid rehousing programs, which are temporary housing programs, even though individuals have a permanent lease, those rapid rehousing service providers, both city-funded and county-funded, do all of their own case finding, and we may look at that in the future. In addition to the county Office of Supportive Housing, behavioral health staff, and contractors, we do have a lot of medical outreach, mainly provided by our Valley Homeless Healthcare Program. They operate, of course, their own clinics, one at the Picardo Reception Center and one off of Alexian Drive. They also do what we call backpack medicine. A team of doctors, nurses, social workers go out into the encampments and provide medical services. And then this other downtown streets team's basic needs grassroots. Downtown streets team, while they do operate specifically, with unsheltered persons, that's really about engagement or enrollment in a sort of specific program, and not just outreach per se, but I think it is a part of the kind of the network of outreach services because they are actively communicating and engaging with homeless persons there. And then, of course, we have just a lot of community members, faith-based organizations that are actively doing their own outreach. In addition to kind of the mobile outreach, the outreach to persons on the streets, I wanted to highlight that we do operate a variety of kind of community facility-based outreach and kind of community facility-based mental health programs. So, for example, most of our emergency shelter and transitional housing programs countywide have some access to behavioral health or medical services. And sometimes this is provided by the organizations. For example, Julian Street Inn, which is about 83 beds, all for persons with a mental illness. They have a psychologist who's there, oversees all of their programs, and they bring in interns to provide behavioral health services. The Picardo Reception Center in San Jose as well, 250 beds. Here we have a Valley Homeless Healthcare Clinic co-located with the Picardo Reception Center. In addition to the shelter programs, transitional housing programs, we have drop-in centers that offer some medical services. Examples of this include the Cathedral of Faith, for which sort of in the basement area, the Gardner Family Homeless Healthcare Program operates a clinic. And then, for example, in the Palo Alto area, the Opportunity Center, they have the Peninsula Healthcare Connection providing some medical services there. I mentioned the health clinics, primarily through the Homeless Healthcare Program. And then finally, through our various kind of safety net and program offices, we co-locate behavioral health services and co-locate kind of housing assessment services. I mentioned the Resource Reentry Center, which has a Valley Homeless Healthcare Program medical clinic, but also has a behavioral health team. Our General Assistance Office, for example, has 4 clinicians assigned to work collaboratively with those offices, and there's a whole behavioral health team assigned to the CalWorks office. And of course, we'll get to that later, which is there are some behavioral health services at the collaborative courts. And then finally, all of these are, to the greatest extent possible, coordinated with the Behavioral Health Department. As Tony mentioned, she's adding intensive outpatient programs for crises. We would rely primarily on the mobile crisis, the psychiatric emergency response teams, and then, of course, the emergency and acute services provided by behavioral health. And finally, specific dedicated teams who do nothing but outreach to homeless individuals totals about $4 million countywide. While this network of services is more robust than one might imagine, I think there's some opportunities for improvement. And specifically, I think it's in 3 areas around coordination. We all fund outreach activities, but we need to make a better effort at coordinating, even if that means just it's making it easier to find a person. Second would be optimization for those agencies that are providing mental health services. Can we find a way to put that under behavioral health so that maybe we can leverage especially mental health dollars for that? And for example, in the RFP that the county just released for emergency shelter and transitional housing services, we partner with the behavioral health to incorporate their funding into that program so that we can see how to better provide mental health and behavioral health services at the shelters. And then strategy is just how do we work together better? And then finally, my last point is that, again, the success of the outreach engagement programs is entirely dependent on our ability to connect them to long-term permanent housing resources. Jackie?
I just wanted to clarify that $4 million was for the mobile outreach teams, and it didn't cover all the other outreach or services that Key described. And then lastly, I was just reflecting as Key was talking about 43% of homeless people identified or self-reported as mental health, and I really think that that is underreported. My experience in this field and even with non-homeless people, is that most people aren't willing to admit or feel comfortable admitting that they have a mental illness. And so I think that 43% is probably greatly underreported.
Thank you. Thanks both Key and Jackie. Now I know, Key, you alluded to the final section here, which relates to the adult treatment court, which I think many of us previously knew as opportunity court. Is that right?
We've been referring it to as behavioral health treatment court, but
Yes, we'll take your name.
Yes.
We'll move on to this final section, then we'll come back for questions. Thank you.
Okay, thank you. It's me, once again, Key. The presentation here provides an overview of the different collaborative court programs in Santa Clara County. California's trial courts are overseen by the California Judicial Council and the Administrative Office of the Courts. The trial courts are organized by county, so the Superior Court of Santa Clara County is further organized into departments with a judge assigned to each. The Superior Court here has about 100 or so departments. Through these departments, Superior Court operates about a half dozen programs in which judges bring together justice system representatives, the defendant, other government agencies, service providers to collaboratively develop treatment and supportive service plans as alternatives to jail or full sentencing. These types of programs are known as collaborative courts, and they serve individuals and families with many of the stressors that we've talked about, which is including homelessness, housing instability, unemployment, or underemployment. Of course, the traditional partners of the court, the public defender, the DA, and the law enforcement agencies, probation, and the non-traditional partners are the county safety net programs and social service providers. All of the collaborative courts assist individuals with substance use disorders or have crime behaviors involving the use of alcohol and drugs. Some of the courts further target individuals with a mental illness and or target the individual and families involved in a particular safety net system. In Santa Clara County, the Collaborative Drug Treatment Court program, here termed the Adult Treatment Court, includes 4 different departments, and 2 of them have specialized programs, one of which we have called out specifically and is listed as the Behavioral Health Treatment Court. In addition to those courts I mentioned, the other collaborative court programs include the Family Law Treatment Court, which is a voluntary court-supervised program for parents with custody hearings in family court. Another one is the Dependency Wellness Court for families involved in the child welfare system, and then the Palo Alto Review Court. Here, I've provided some information about the Dependency Wellness Court to highlight 2 things. One is the complexity of bringing together all of the different necessary providers. The Dependency Wellness Court is separate from a dependency hearing court, which is the court that decides whether or not a family can maintain custody of their kids. The Dependency Wellness Court is for the individual parent to help them overcome any alcohol or substance use related issues. In order to support the individual parent, we bring together, of course, the law enforcement and criminal justice partners, but we have to bring together the individuals to support the child, sometimes referred to as the child advocate, and then we bring together the various individuals to support the family member. And the other thing that I'd like to highlight here is the Dependency Wellness Court. When they surveyed their participants, 71% of them reported housing instability, including homelessness, severe rent burden, or doubling up. The Behavioral Health Treatment Court originally began in 1995 as kind of the sole drug treatment court in Santa Clara County, and now it has expanded to other specialty courts, and Behavioral Health Treatment Court is really focused on individuals with a mental illness and or a co-occurring disorder. The Behavioral Health Treatment Court sort of has special days or calendars in which it also serves a subgroup like parolees or veterans, but still it's focused on homeless individuals mainly with a mental illness, and it serves approximately 1,500 persons annually. And of course, the goal is to integrate substance use treatment services and mental health treatment with the judicial supervision to promote recovery and reduce recidivism. The court partners have traditionally been the behavioral health department, but they have been expanding as we expand our supportive housing system. The behavioral court is an important part of our effort to reduce and prevent homelessness. The behavioral health systems criminal justice division is a set of intensive outpatient programs that is really there to support the referrals from the behavioral health treatment court, and now we are trying to integrate housing activities and programs there as well. And the reason is 75% of clients coming through the behavioral health treatment court report as homeless or unstably housed.
So let me just jump in there in terms of making that connection back to the Opportunity Court. There was a time when the city staff were working closely with our outreach and our caseworkers to connect them to this court to ensure that clients that they were working with that got into trouble with the judicial system got through this court and were placed through here in order to get diverted and not sent to prison. So there was more of an effort there on education and coordination on the city side with this particular court.
And earlier this year, we began to assess the behavioral health treatment court clients for housing services, and we found that of the 104 persons we were able to assess, 91% of them were homeless and needed permanent supportive housing. Finally, we recognize that increased coordination not with the behavioral health treatment court and all of the collaborative courts is necessary. And then just recently we received, or the Superior Court received, a federal grant from SAMHSA to outstation additional clinicians and supportive housing staff in order to improve services, not just at behavioral health treatment court, but the other collaborative courts as well. And then I'd just like to highlight two other kind of collaborative courts that may have relevance here. One is the Palo Alto Review Court in Palo Alto. That court is not solely focused on persons with a mental illness or co-occurring disorder, but it operates much like the other courts. The key here is that perhaps because it's a smaller community, it partners very well with something we call the North County Alternative Sentencing Program, which this is kind of convened by the Public Defender's Office, law enforcement agencies, service providers come together to discuss the cases that are going through the PAR court, or perhaps that cases that can be referred to the PAR court, and it's just a way to kind of coordinate services before, after, and then during the court process. And then finally, we have something called the Community Outreach Court, which is also overseen by Judge Manley, and this is these are court proceedings that happen at the Reentry Center, and it's the county's Resource Reentry Center over there on Mission Street, and it's a sort of similar to what we used to call the homeless court. Individuals who are homeless or of low income come to the court, present their cases, and these are minor cases, and some of their fees or are reduced or dismissed. Thank you.
Great. Is that the entire presentation on this section? Thank you very much, Key, and thank you, Jackie. Appreciate now that we've gone through the entire presentation. I really want to thank our colleagues at the county and also on the county board in particular, because I'm guessing you've all heard this many times, but to many of us here at the city, this is very much new and very educational. So I appreciate everyone's patience. Where we left off, I think I interrupted after Councilman Camus asked a question about Laura's Law, which I believe we understand was in the AOT presentation. And if I could just put that back on the floor then and maybe refine it slightly by saying, I think you indicated, Director Tolis, that it would require the board to adopt AB 1421 and issue some findings. Is the county decided to do that or not, and why or why not?
Before we get there, Mr. Mayor, and forgive me, Councilmember Camus, that I passed on the opportunity to make opening remarks. I think at this point, an hour and 15 minutes in, it might be just helpful to tee it up this way. The mayor reached out to my office earlier this year and said, we've got some areas of common concern. Could we talk about that? We did. We met with folks at the County Government Center. That was a helpful first conversation. The follow-up to that, as my colleagues will recall, was that in August of this year, I brought a referral saying, hey, it looks to me like it would be helpful at the mayor's request to have a joint meeting to have this conversation. And obviously a lot of the work that the city does is unfamiliar to some of us on the board. Obviously a lot of the work that the board and the county do is unfamiliar to folks on the council. But to sort of cut to the chase here before we get to the issue, Mr. Mayor, I hope you won't mind if I put you on the spot, but essentially what you said is how can we do more and how can we do it better? And how can we do it together so that the work the county is doing is directly connected to the work of the city and back and forth. So I just want to exhort the county staff as we respond and interact with our colleagues from the city to be sort of, bottom line it for all of us, which is, are there opportunities to do more? Are there opportunities to do it better? And are there opportunities to get better connected so that the two organizations aren't off doing their own thing? Excuse the interruption, but I think that might help focus the discussion a little bit.
Yeah, very good context. I also want to thank President Smedian for his efforts to convene us on this issue. Director Toyce.
Do you want to ask your question again, your specific question? You were talking about concerns of people in the community.
Yes. So in regards to this Laura's Law, it's been implemented in other counties. We just heard from our police chief that 71. I'm trying to remember what you said exactly. 71 individuals have been taken in for evaluation more than 10 times each, and that is exactly what Laura's Law is being used for in other counties, and I kind of wanted to find out, is it coming? Are we going to be discussing? Are the supervisors going to take it up, and if so, when?
That's a question for the supervisors. They have to make the decision on that. I'm the staff person in this. I would say that all of the programs that I'm describing to you are very similar to Laura's Law, and they are voluntary. And we're adding services in Santa Clara County that this county has not had ever, based on what the needs of the community are. So we are standing up an additional 900 slots for people that have really high needs who are currently not receiving the level of care that they require. And I'm very wedded to expanding what we're doing with crisis and expanding our service delivery so that we can get people involved in a variety of services so they're not on the street. But the decision making, anything on AOT, is really related to the Board of Supervisors, not to staff.
President Smedian or
I want to defer first to Supervisor Chavez, and then I'll follow up. I think it's probably fair to say that she and I have been more engaged in this conversation over the last couple of years.
So what we did do is we did bring actually a referral to the board to get staff to give us feedback about what the appropriate approach was. And really, my belief is that what the staff had asked us to do was give them a chance to stand up these other services, in part because the concern was that AOT was relatively labor intensive for a relatively small group of people. Mm-hmm. Now, that being said, the other thing I would just acknowledge is the 71 people that we're seeing in and out of one single system are also people that we're trying to get into other programs that we already have for people who are high need. And my suspicion is that a significant number of those 71 are also homeless, which brings them both in intersectionality, both with what the work that Key's doing and the work that Tony's doing. The other thing I'll just add that has become clear to us is that we have another system in the county, and that is our public guardian system, that frankly we have not engaged at the level that we would like to. And that public guardian system actually already allows us to provide the kinds of support that that Tony outlined in AOT. And so one of the things that we're as a county, I think, trying to better understand is how strengthening that program and expanding its leadership and role in supporting people who are mentally ill is another way for us to come at this problem. And then one final point that I'll make, Johnny, and I don't know how much opportunity you've had to take a look at what is happening in other counties, what I have learned is that there are very few people that are actually committed under Laura's law, and that what actually happens more is the intensive services around that person, the engagement of their family, the engagement of the courts, is usually leveraged to get the person to take the kind of services that they need. And I think the point that Tony raised that was really important is that committing someone under this does not force them to take medication. The strategy that they're trying to use in our partnership with both the courts and the nonprofits is to get someone to take their medication, because ultimately what we want them to get is enough treatment to be able to make the kinds of decisions for themselves, both along treatment and frankly to stay in treatment than they do now. So for me, I think, and I'm just speaking as one member of the board, what I wanted to do is see the work in all the different programs and teams that I just laid out, what that looks like, frankly, by about next fall. And if we're not seeing significant improvement, then take the step to pursue Laura's law with that specific framework. But my suspicion is that the work that's being done now is going to really meet the bulk of those needs, because what I really want to see is people taking the medication and getting the services they need, not just being committed.
Yeah, well,
and I don't know if I'm sorry, Johnny, Tony, did I say anything that was inaccurate?
You actually nailed it.
Okay, I just want to make sure I understood all this. There's a lot of moving pieces. I think the point the Chief raised earlier about this feeling like a watch is right on, so.
Yeah, and I'm not talking about the fact that they are not taking their medication. This program actually, it's involuntary. They are committed. And so they're off our streets and not getting wrapped up in potential disputes with law enforcement, which sometimes end in a way that we don't want them to end. And I fear for them that they will tangle with police and they will do something, assault a police officer, and then it can go downhill from there. We've seen it before. And for these 71 people that we had just heard, an incarceration program is probably the better option for them, whether they take the medication or not. And so I appreciate the fact that you're looking at how other counties are doing it, but I'm also a little scared that some of these folks won't get the help as fast as they need, and sometimes that help has to be involuntary. That's all I'm trying to say with this, and it's been working. In fact, the state. My staff has been analyzing many counties, including San Francisco. The state is actually strengthening the incarceration laws for mentally ill folks. In fact, something just recently passed last week. And so I'm hoping that you do consider it sooner than later, because we have to do something about those folks. The cost is also incurred, when we have to use our police officers to basically become psychologists in some of these situations, or if they're not trained well enough, things can go downhill from there. And that's what my most fear is, if those people become a harm to themselves or other citizens or police officers.
And I would just say, I think all of us share that concern, and I think what we're trying to best understand is what is the most effective, humane, lawful way to go about this. And I'll also just say, Tony, how long have you been with the county now?
3.5 years.
I know it feels like forever, but it's only been 3.5 years. But one thing I will also say is that the descriptions that you heard of the programming and all the new work that's being brought online, a lot of it is relatively recent. And I would say, and I think the point that Supervisor Simitian raised is a really good one, which is, I think we're in the process of understanding and learning how to do all of this right and well. And so I think, Councilmember Camus, the points you raise are not lost on me, I think on my colleagues. I do think that, again, I I'm really committed to making sure we're providing services to this community. I think the whole board is. I think you can see that by the fact that we probably invest more of our general fund dollars than any other county in the state outside of San Francisco to provide services to this population. So I think you know that there's a very meaningful commitment, and we're certainly, and I certainly am worried about public safety as a primary issue.
And President Simonian?
Thank you. And if you'll bear with me, just a little bit of personal history on this. I actually voted for Laura's Law as a member of the California State Legislature in 2002. I had just come from being on the Board of Supervisors from 1997 to the year 2000, so I had been schooled by the mental health system at the time, and then arrived in Sacramento just in time to be confronted with what was then a very contentious debate. While Laura's Law, as it was then referred to, passed with a overwhelming majority in my recollection, there were a lot of folks who either voted no or who abstained, and the reason for that was not ideological. There were folks who you would describe as coming from the left, as well as folks who were described as coming from the right, and a lot of that had to do with concern about civil liberties and about concerns that medication might be involuntary, and of course ultimately the way the law was passed and has been implemented, I want to underscore the fact that there is no involuntary medication, and let me just look to Ms. Tully's to confirm that. And Councilmember, just to clarify, under existing law, my understanding is that there is not involuntary commitment with the exception of perhaps short-term hospitalization stays for assessment purposes, but I don't want people to think that if we snapped our fingers and suddenly adopted this practice that we would have either the ability for good or ill for folks to be involuntarily committed, depending on your point of view. That's simply not the way the process works. One of the, I think, I'm going to go to Dr. Smith in a minute if he's got comments or questions that might be helpful, but Ms. Tully, if I misrepresent, you'll correct me, but we had this conversation more than a year ago. At the time, our folks in behavioral health said, could you give us a year to see if we could stand up these other services? Now, that year has come and gone, and essentially what you're saying is, could we have another year? And fair enough, that's where we are. I just want people to sort of understand that that's the timeline that we have been on and appear to be on going forward. There is great debate within the mental health community in our county about the advisability of using this AOT process. Some of the folks are concerned that once mental health services start to become threatening to people, that people who are already not always inclined to seek out the help will be even less inclined to seek out the help or less accepting when the help is offered to them. Supervisor Chavez has referenced the fact that one of the benefits that appears to be manifesting itself in other counties where they've moved forward is that folks engage with the system and have these services. Ms. Tully's is saying we're trying to see if we can provide that benefit without using the law to that end. There are some folks who argue, no, you really do need to use the law because of what's called the black robe effect, which is that when people end up in a courtroom and are sitting there with a judge, they say, ooh, this is serious, I guess we better get ourselves organized and take advantage of the system. That's part of the back and forth in the debate. But I would just counsel, and I personally am, as you can tell from my on the one hand, on the other hand, have ambivalent feelings about this issue. But when I finally do get to a place where I have a clear point of view, it will be mindful of the fact that it is not the panacea that some people suggest it is. Whether or not it would make an incremental net improvement, I think is a tougher call than we might think. And if you'll bear with me, I would like to just go to Dr. Smith, who I think I see through the dais.
Yes, you can barely see him.
There you go. Dr. Smith, anything else you want to answer?
I'm over here. Yeah. They put me over in the corner and make sure I didn't say anything bad. No, I just wanted to add a little bit of perspective to the discussion, reminding everybody on the dais that enacting Laura's Law will not prevent those 71 people from being seen or being on the street. Laura's Law does not incarcerate people. It is a way of compelling them to get treatment for a short period of time, and then they are basically removed to outpatient treatment. Incarceration really happens at the jail, and that's the sad thing about the current reality in our county and across California, that the only constitutionally mandated mental health facility in the county is the jail. And that's clearly not a good place to be, as witnessed by what we had here as a disaster a few years ago with the Tyree murder. And so I don't want to give people the impression that Laura's Law means that, you know, people will be locked away and incarcerated. It's really a treatment modality, and we offer all of those treatments right now voluntarily, which is not to say we won't put the issue before the board, but when we do put the issue before the board, I sincerely hope that people don't believe that that will solve all the problems.
Thank you, Dr. Smith. I just want to distinguish two very important and different terms. One is incarceration, the other is residential commitment. Is what we're hearing that there is no residential commitment with Laura's Law?
There's not.
There's none. Okay, that's helpful. All right, thank you very much. Okay, I know we have several folks who'd like to speak, so we're going to move on. I have Councilmember Perales' computer telling me someone would like to speak. All right, thank you, Councilmember.
Thank you. Well, first off, thank you for the presentation as well. And let's see here, I've got a couple questions. Maybe we'll go back to the regular order. I was going to go in reverse order based on the presentations, but I'll go back to the beginning since that's where we're discussing now. In regards to a lot of the work that the county is doing on suicide prevention, I know that we had reached out to the county and attempted to get a specific suicide prevention policy here at the city. I wanted to see if the county has a suicide prevention policy and if they feel they would recommend one for each individual city within the county.
We actually have worked with many cities in the county. We do have a plan. We've shared it with cities, and we've also shared it with many other counties across California. So that's available.
And is it something you would recommend our city or other cities within the county?
I would recommend
to
any
adopt?
city to have a suicide prevention plan.
Great, thank you. And our city will have an opportunity coming up at in the new year with our next priority setting. So thank you for that. In regards to the partnership between your department, Tony, and our police department, I'm really interested a little bit more in expanding on the possibilities of the rapid response partnership. And I'll tell you that I still have an opportunity to ride patrol once a month as a reserve officer. And although it is seen all over the city, certainly within the downtown core, it is seen more often, and not just with police officers, but quite frankly, the effects of homelessness and mental illness and its draw on our services is seen across the board, from our Parks Department, service personnel, rangers, clearly our housing team, the fire department, right? A extreme number of calls that they're responding to, but I get to see more firsthand with our officers. And when I ride, and the chief probably hears this as well, but when I ride, you could imagine at times the officers that I'm riding with take advantage of sitting next to me for 10 hours and lobby me on things like saying, hey, what are we going to do about the issue with homelessness, right? Because, and I get to experience it with them during those rides, and we will go out to several calls involving people with either that are suffering from mental illness, homeless, drug addiction, or, as you know, all the above. And so when we do respond, and this is something that I really appreciate the partnership that behavioral health has with rapid response, it's important because a lot of these issues are not necessarily one that would require a police officer to respond to, right? Or maybe a police officer may not be the best person, but they tend to be the first person, right? Or maybe a firefighter, right? Our public safety personnel. And I think in those situations, if we can get maybe the best person to actually be there as well, somebody that is an expert in these behavioral health services, it could make all the difference. And I know that partnership exists now within this rapid response, but I wanted to see how we can, or when we can expect to see that actually expand. My understanding at the moment is that it's sort of a Monday through Friday, 8 to 5 kind of deal, and you can reiterate that. But so when can we see that expand? And then what would it take to actually get that to expand?
I do want to show you how strong the partnership is, because the chief just said, I'll take first crack. He said, okay, you go first. So you go.
First of all, council member, thank you for giving me my first idea of a memo today that I have to put out for everybody that rides with you with regards to conversations in the car. I'll write that down and remember that. The other thing I'll say, yes, currently
It's
right
not
now,
during calls time, it's just downtime, Chief.
First of all, yes, right now it's not enough, and I don't think Tony is sitting here and tell you it is enough. It's the programmer now is 8 to 8. We have limited individuals that respond with us Monday through Friday. Obviously, if you break your leg on a Monday at 2 in the afternoon and an ambulance arrives to take care of you, if you break your leg at 2 in the morning on Sunday morning, you should have someone there to take you as well, as we expect, right? And so Tony and I have discussed that. If there's anybody that understands staffing limitations, it's me. And I could tell you, if someone a few years ago and even still now tell me that we need more law enforcement officers out in the street, I would look at them with a straight face and go, yeah, I know, we do. And those are the type of conversations that I've had with Tony as well, and I'll let her get into the specifics as to why those issues are there. But ultimately, what the master plan really is at some point is to have a team of officers, as Tony discussed, that's actually partnered with clinicians inside the police car. That's the master plan. Now, obviously, we have a lot of holes to fill, and we are rising and getting bodies. So we have a lot of places that we need officers. But the master plan, really, for me, is to really be able to cover all shifts in divisions with a team of officers. That a clinician is with them, so we can do exactly what you're saying. That's down the line, right? So at first, I think one of the first steps is really to try to get this up and running. I know one of the other plans is to get this at least Monday through Friday up until midnight. That's kind of like phase 2. And I think phase 3 and down the road is what our goal is, to get 24/7 crisis response with, and we're talking as a county, and I understand, we're dealing with San Jose and our city of over 1 million, 181 square miles, to know that we need more people that are, committed and devoted to responding with us. But that's where we're at from our perspective. And if Tony, if you can. Yeah.
So as I mentioned, we're in the process of interviewing several candidates this week. Hopefully some of those will be selected. On a broader scale, there are a couple of things. Right now, we've had for a long period of time 2 law enforcement liaisons who have been police officers and command staff, and they work for the department, and they work with all of the law enforcement agencies. The bulk of the work is actually with San Jose PD. So there have been a number of incidents since we've started the mobile crisis teams in January, where it may be off hours, it may be something that's really intense, and the law enforcement liaison calls the mobile crisis team, and they've gone out. And now that they've been trained as negotiators for both the Office of the Sheriff and San Jose PD, if there is an incident that is beyond the current hours of the mobile crisis teams, our trained hostage negotiation clinicians will go out and meet those needs. So that's already in place. It's not, we don't have 24/7 yet, but we really want to meet the needs of law enforcement. And the sheriff and San Jose have been very clear we would like to have these services. I think the other thing is, when you're talking about the people that are homeless, and I'm listening to all of the comments and Key and Jackie's comments as well, in behavioral health, we're really looking at the homeless, the incarcerated, and the high utilizers at EPS as all having very similar needs. And so the work that we're putting into place and these different levels of very intensive clinical outreach, which takes a lot of time, is really to try to get those people in services. So one of the whispers that Chief Garcia and I have had, and I've got counsel sitting here, they'll have to say yes to this, but he has a list of names of the individuals that San Jose PD has brought to EPS over and over again. I don't have that knowledge. So we believe, because this is coming from law enforcement to our department, we have different regulations on privacy, that he'll be able to share the names of the 70 high utilizers, and what we'll do there is look to see if those people are in our system, and if they are, we'll intensify our outreach to make sure that they're in services. And I want to say that because that's the kind of collaboration that we have, and it's really been very frequent, like let's try this and let's try that. So I think I'm very hopeful about the way that we're working, and I actually want to go on a ride along. I've told the chief I want to do that too. Does that answer your question, sir?
Part of it. The only other part was how or what would it take to actually get to that level, the 24/7?
Yeah, it's, it is in behavioral health in California, but most notably in the Bay Area, there is a historic workforce shortage. It's way beyond the schools. It's that with the new regulations and what we call parity language that requires the commercial insurance plans to provide some version of mental health and substance use treatment, licensed clinicians are in very, very high demand. And the number one competitor in the Bay Area is Kaiser. Kaiser pays more than anybody. They had a lawsuit that they had to address, and their work is very different than ours. So they work with a population that doesn't have the serious mental illness. It's more of a 9 to 6 kind of job. The population, as Key described and I described, our population is very ill, low income, has many, many different needs. So you have private healthcare systems, you have health plans, you have what do I want to say, medical groups, many, many, many different organizations, all in the Bay Area, all trying to hire these clinicians. Now, we are a draw because we're a county and we have a good reputation. But as I said earlier, we really also rely on our CBOs, and they've had challenges hiring, so we've increased rates there. And for the county, our Employee Services Agency is doing a very special ongoing recruitment, and we are interviewing as soon as somebody applies. So we're just going to do that until we're maxed up. And I know in talking to Dr. Smith that if we need additional codes for additional staff, I know that we'll be supported for that.
Thank you. Oh,
Director Tolis, thank you very much for the thorough response. I just want to give everybody a time check on this. We have about 20 minutes to go until the lunch hour. We have many members of the community who would like to speak, and we have 3 more folks on the panel who would like to ask questions. President Smitty and I have discussed, while we are certainly talking quite a bit about homelessness already, that perhaps homelessness, that section would be the first topic of conversation in our next city county meeting, since we know that is a very deep topic that we'll need to address, engage in much more significantly than in the limited time we have here. So let's move on then with questions just on this, and then we'll wrap it up with public comment. Councilman Frost, do you have anything more?
yes, the next meeting you're talking about would be a year from now?
Well, hopefully sooner. We're working on it. We're going to find a date. Okay. Yes, yeah, if you behave well, Supervisor Chavez says we can come back sooner.
Okay, because the next question I was going to lead to was more regarding homelessness and the coordination efforts, and so if that's something that can wait till the next meeting, I'm comfortable having it wait. If you think now is more appropriate.
Well, we are talking about homelessness now in the context wholly of mental health, so if it's a very succinct question with a succinct answer, we can take it.
Okay, we'll see then if it could have a succinct answer. I don't get to take up that part.
Okay.
Just the question. Well, first off, thank you. That absolutely answered my question, and I hope it helped my colleagues as much as it helped me, because part of the issues that we have, right, in this understanding of responding to community concerns is not knowing all the answers to everything, right, and not knowing why something can or cannot happen. And so I appreciate that, and that does answer my question. So this, and Key, could be for you, could be maybe for Lee or Miguel. This is in regards to the partnership, as you were talking about, Key, and you yourselves within the county wanting to partner better, understanding that these issues all do sort of cross over: homelessness, mental illness, drug and alcohol addiction. So last year, actually, through direction coming from actually the police department, Captain Dwyer had asked, hey, why don't we have something around homelessness or those issues like we do with the Mayor's Gang Prevention Task Force, where there is this larger collaborative effort. And that kind of kicked off a little bit of an opportunity where I reached out actually to Supervisor Chavez, and we convened a first meeting last year, and Key, obviously you were there as a part of that. And my understanding now is fast forward to this year, Lee, Miguel, and obviously teams on both sides of the court have said, yes, this is a good idea on how do we collaborate maybe better just to have this understanding, and not necessarily just elected bodies like this, but the individuals like yourselves who are doing the work. So I wanted to just get a timeline on that and what that might look like actually moving forward.
Thank you for the question, Councilmember. Lee Wilcox, Chief of Staff and City Manager. You are correct. A joint team between the city and county has been put together, made up of roughly 16 department heads on our side, including housing, police department, fire, parks, as well as Tony, Key, social services, Eddie and Jackie from our side, with the goal of building in and integrating regular collaboration into our problem solving, our strategy development, and how we optimize these services for our community. So we're continuing to meet regularly. What Miguel and I were going to say under agenda item number 6 was we hope to have a fully more robust report and report out to all of you at our next city-county meeting. But I would think that we would independently be updating both the board and the council in the meantime of these efforts.
Thank you. That answers it. I will expect that report out then officially to the two bodies at the next meeting, but I look forward to the status updates in between. So thanks.
Okay. Supervisor Yeager.
Yes, thank you. Just a quick comment on Laura Law and then a question about the Sobering Center. Part of Laura Laws, if you implement it, you are required to have voluntary services already in place. And so it isn't like you pass it and bingo, it's in action. And so certainly what we've been doing over the last several years, but the last year in particular, are looking at the gaps that we have in adult behavioral services. And that's sort of where you come into the in-home outreach teams and the mobile crisis teams to be able to do that. So even though AOT continues to be controversial, and we'll see ultimately what the board decides to do, we're putting everything in place that should we want to adopt Laura's laws, where at least we've done everything we needed to do under the law. Yes. So I just wanted to make that clear for everybody. And then as far as the Sobering Center, we're very excited that we have that program, and a number of cities have signed MOUs with us, but we haven't crossed the goal line with the city of San Jose yet. And I didn't know, Chief, if you had any comments on where the city was with that, or is there anything that we can do to give more information so that the city can participate?
Well, we may not be at the goal line, Supervisor, but we're driving. We're like on the 15 right now. And, I will tell you that I'm in full support of it. Anything that enables our police officers to get back out in the street to deal with more serious crime is something that I'm for. Right now, we're just working with our city attorney's office to ensure that the dots are dotted, T's are crossed on the MOU.
Is there anything that the county can do to move the city attorney's office right along?
I think if they agree with our city attorney, I think we're set. If they do that, we're good. We're golden.
Put.
Supervisor Yeager, I'll ditto that.
Oh, right.
All right.
We got it on the record. Thank you very much.
In all seriousness, I think I've just looked into that. There's been some back and forth on the agreement, so hopefully we're almost there.
Okay. Hopeful. It's either Councilmember Jimenez or Arenas.
Well, it's both of us, but I'm going to forego my questions because I want to hear from the public, but I think Councilmember Arenas has one or two questions.
What a setup for me. I'm still going to ask the questions. Okay. Well, thank you so much for the presentation this morning. My question is around the behavioral health. And when we were going through some, I forget which one, but you talked about some of the systems that have been changing, and something caught my eye, which is the Kid Connections system. And you said something to me that brought it back to my times in First Five. And you said it was award-winning. And it's award-winning because, in my eyes, they managed to create systems change, right? They created systems change so much that they're maximizing their Medi-Cal reimbursement monies so that there is longevity in those programs, correct? And I think that when we see that there's that possibility of connecting public health
with a service with many service providers throughout the city of San Jose that and the county that provide mental health services and support services for our families. If that can be done, we can replicate that and do that in other arenas, in other areas. And so my question is this: when we talk about behavioral health or we talk about homelessness, and I appreciate that there's already a group or a committee that's taken a look with just 16 department heads meeting and discussing this, but I wonder if we're looking too far and we're not looking at what we've already done and managed to accomplish, which is this systems change, and have we ever considered expanding on that and replicating it for the children 16 through 24 and adults, so that there is a holder of, if you will, of behavioral health services, and it's not spread throughout all the service providers in the city of San Jose and in the county.
So I'll be very brief, but this happens to be one of my passions. I'm particularly proud of this. What's happened is that there's a great collaboration for these young kids who are presenting with issues and their families. And we work with a number of contract providers in the community to do this work. It is absolutely systems change. And we're now adding to our children and youth continuum a state-of-the-art first episode clinical intervention for youth that are having their first mental health issue. And the other thing that we're doing and launching is a first in the country, and that's something called Headspace, which involves mental health, substance use, primary care, education, and employment. Within, we'll have one here in San Jose and another one on the Palo Alto side. It's an internationally known model, best practice to do prevention and early intervention. And we've been told by colleagues at Stanford and nationally that once these two systems are in place, these two new programs, that we will probably have the strongest continuum of care for children and youth in the country, from 0 to 5 up through the Tay. We have a great team of people, fabulous providers. It's really important work. Now, what are we planning to do? All that I'm describing today is on our adult system, and we're using all the same principles in our adult system as has taken place in our kids system. Not that there aren't things we can improve, we'll always improve, but that same framework and that same approach is what we're doing now for our adult redesign. And we're also looking at our jail diversion and people coming out of jail and adding that into what's the best way to approach that population. So we're very much involved in how we change the systems, how we work with all the partners, always to benefit the people we serve, 100%.
Wonderful. I'm really excited to hear that. I think the city of San Jose is another system. And so I think it for me, a begs that question of how are we going to fold into this? If you're already leading that charge in terms of system improvements with that age range and then the adult population, we don't need to recreate what our partnership, what our coordination or optimization or strategy development, it's already there. We can just replicate it and move with those different topics in mind, the homeless population with the outreach or the behavioral health. I think it can apply to either one. Wouldn't you agree?
I would agree. I think it's a more challenging population. Adults who are homeless, incarcerated, frequent utilizers. It's a much more challenging population. I'm optimistic with the county. I'm very optimistic with the partnership with the city, but it's going to take all of us to address those needs.
Absolutely. Thank you for answering that. The second question that I have is just, I think you all do it really well in terms of providing some gender-specific services. And I saw that in the Dependency Wellness Court. I also worked in the Family Wellness Court when it was originally called Family Wellness, and it was a pilot. And so one of the things that I was thinking about is gender-specific services, and I don't see them throughout the presentation, but I'm sure they exist. I think for me, one of the items that I've been talking about is, I can't hear myself think, is women and children. And that has been missing in this picture, and I really would like for us to begin talking about that very seriously, because with women, there's children, and in order to move women forward, we need to make sure that there's housing, that there's childcare, and that there's workforce development, and all of that is tied in. And I see both of these areas as issues that are very impacted in families. I've always said that our families who are homeless that have children are couch surfing. They're not out there because they don't want to put their children in danger and be separated, and they know that. And so I think we need to make sure that we're always talking about some very gender-specific strategies.
If I could ask for a very succinct response, because we're really down to the final minutes.
I would just say I'm looking at Supervisor Chavez. There are a lot of those initiatives taking place in the county, and it might be useful to learn more about what we're doing.
And if I could just offer that perhaps what we can do is get a meeting of those interested with Tony to have a deeper discussion about this. I think it would be really helpful. Thanks.
Great, thank you. Councilmember Davis?
Thank you, Mayor. I too want to thank county and city staff for putting all this information together and sharing it with us today. It's a relatively new topic for me, so I've appreciated all this information. I'm still kind of trying to put it together. So I want to thank Councilmember Arenas and Supervisor Chavez for their comments and questions that have kind of helped get down into the details that I didn't even know were there. So I appreciate that. I get asked a lot about what we're doing for mental illness specifically, because it's a very visible problem, as we've been discussing. And so I want to make sure I understand what's available. The first set of slides, again, I'm still trying to process them, but when you had the continuum of care slides, from the discussion, I think I understand that maybe not all of these boxes are available in the county yet. Is that correct? For, say, adult and older adult continuum of care?
We have a number of additional services that we'll provide, but what you see is what we currently have. I think the only one that's changed is the sort of community treatment program, which we do not have in the county, and we're standing up. But that reflects the variety of services, the continuum.
Okay. What would you in a comment from Councilmember Nguyen, I think you offered to provide for us kind of what's available and who we can contact. I would really appreciate that, and if you can connect it to this continuum of care, just so I can get a sense of, since it's new to me that there is a continuum of care and what they look like, and maybe what the names of the programs are in our county would be very helpful. We do get asked about this pretty regularly, and knowing that there are more things coming and down the soon, and what the timelines are for those is helpful for us to be able to communicate to the community. Thank you.
Thank you. And Councilmember Diep.
Yeah, so very succinctly, I'm just trying to tie this all back to what the city can do and how we can help this. I know we're trying, as a city, trying to push for more housing to address this housing crisis. Today we're talking about behavioral health, mental health, substance abuse, and that is kind of a subset of the larger issue of homelessness. But through what I've seen here, there are services that need to be rendered to these individuals, help getting back on their feet, help taking medicine, et cetera. So I guess the thrust of my question is, what would the county say to the city as we're going about trying to build more housing and doing inclusionary housing and spreading out different levels of income around different housing sites around the city? In the particular case of people with mental issues, do you feel that they on the whole are independent enough to kind of have their own unit in a normal building, or should we be focusing our efforts more on looking at facilities with wraparound services on site? Because would it be too much of an effort to have case managers go all around the city where somebody has their own individual market rate unit or affordable housing unit in some place around the city? Would it make sense to gather them all in one facility? I guess my question.
So I'm going to do a quick response and let Keith provide more detail, but I want to be clear as the behavioral health director, people with mental illness can live independently. They can be stable, they can have friends, and they can have jobs. The population that we're seeing is a really difficult population, the one that we're talking about today, but absolutely people can live in apartments, they can live with friends, that's possible, and I think I need to carry that banner that not everybody with mental illness is on the street and homeless. But in terms of the housing, I think it's for Key to respond to your
Thank you for that
specifics.
clarification.
Yes, I'd just like to reiterate what Tony said. For the most part, the primary strategy we should be deploying is the development of apartments that are deeply affordable and have ongoing service-rich environments for people with mental illness or other disabling conditions. And I think the city has been a great partner in that. Second Street Studios, Villas on the Park, Renaissance Place, we have many of those coming online. And for individuals who have perhaps what we call functional impairments, like they need assistance with cooking or taking medication, then there are other types of independent living that provide more services, and then we're also trying to look at that as well. But the primary strategy is really permanent supportive housing, which the city has been a wonderful partner.
Councilmember, this is Supervisors Committee, and I want to look to the professional staff to confirm something I'm about to say or disagree if they're going to disagree. I think the key point I would make in response to your question is the whole reason people use the phrase housing first is because if people are worried about a roof over their head on a daily basis, they're unlikely to be able to access the mental health care that they need. If they have secure and stable housing, then the chances of their accessing the mental health assistance that they need goes up dramatically. Yes? Hence the phrase housing first, which is, I think, an important part of this conversation.
Okay, thank you, and thank you all for all the information. I know there's one question of great importance, particularly to our housing team, which is, I know you're hiring or working hard on hiring now for mental health professionals to assist with police department. I know we're also hoping to see some assistance with regard to outreach on the PATH teams in the downtown. Is there any likelihood we may be having mental health professional emerge from the county that could team up with our outreach teams?
Well, I think it is a question to the county, which is the city already has a dedicated downtown team. We believe, even though we're seeing success in the downtown team, we would love to see a partnership with the county on having a mental health professional added to that team to provide really comprehensive services that are more intensive in the downtown where we see greater issues of mental health.
Is that on the, I'm guessing by the response at this point, it's not on the.
Well, I think it just became on
Okay,
the agenda.
got it.
Okay.
It's not on the agenda yet, but we're working on it. Okay, great. We'll leave it there. Thank you very much. We have many members of the committee who'd like to speak, so I will ask you all to come down. Thank you for your patience. I should say, because we're out of time, I'm going to ask everyone to limit their comments to 1 minute. Sparky Harlan, followed by Kathy, I believe it's Kathy Forward. Forgive me if I've misread this. Followed by Scott Largent. Megan, I believe it's Willahan. Please forgive me if I've mispronounced or misread. And Bob Stromberg. Come on down, and if you get here first, you can speak first. Scott, come on down. All right, thank you.
Hi, good afternoon, everyone. Scott Largent. I just think a lot of this stuff's a failure. I like to see everybody getting together here. I think we can start figuring some things out. When you try to get on a list to get drug treatment right now, they don't take you in right away. So you're put on a waiting list. It was the same way for me 3 years ago when I was begging and pleading to get treatment. Some of the stuff through our county, drug diversion programs, outdated literature, people are getting high in the parking lot. This stuff is not beneficial to people like myself. I don't know why we don't fix programs like this. It's kind of on both sides of things. I like to see everybody here together. I think that these meetings should be longer, more often. I think there needs to be a task force put into place. I think we need to start vetting these people out, figuring out which ones we can help and which ones we're going to have to take care of for probably the rest of their life. When they stay on methamphetamines for more than 2 years, it's really sad how long it takes to become normal again. So thank you.
Thank you, sir. Welcome.
It's Kathy Ford from NAMI, Santa Clara County. So as a family member and a person working hard about wellness and recovery, this is what NAMI does. it's really wonderful to see, all of you here working together, the collaboration that's going on, in all the different areas. And I think, big thing is that we've really got to fight the stigma about mental illness and what it is and what it isn't. And it's really clear that we need more education, so people can really understand what it is. Because, hearing things about, people who are violent, there's a lot of violent people, they don't have a mental illness. And, Judge Manley's court, I always joke around and say, we already have Laura's Law here. It is Judge Manley's court. He gets it. But, unfortunately, you have to get arrested, to get it. So to see that there's going to be more services, more outreach, because it's really about engagement and, giving people hope that they can get well, that, there is help out there. That's what we need to do. Thank you.
Thank you. Thanks. Welcome. After our next two speakers will be Lisa Ginsburg and Joe Cafaro.
Hi, my name is Megan Wheelahan. I'm from the Law Foundation of Silicon Valley. I work with the Mental Health Advocacy Project. I provide advocacy services to consumers in the county. I want to thank everyone for the thoughtful discussion today and really the attention to keeping it on providing the services that we know work and are effective. As some of you alluded to, the discussions around AOT in other counties and at the state level are often highly polarizing and stigmatizing. We have wonderful collaborations in this county between consumers, between advocates, and mental health providers, and I'd like to keep that going forward even as we explore AOT and pay attention to the ways that language, as Kathy said, around violence and mental health issues can be further stigmatizing and raise even greater barriers to people getting the services that they need. So thank you, everyone, for your attention.
Thank you very much. Welcome, Bob.
Good morning, supervisors, council members, and staff. I represent Destination Home. We're a nonprofit organization and public-private partnership working to make homelessness rare, brief, and non-recurring throughout the county. We also just want to congratulate you on this collaborative approach and making sure coming together to share information and present our homelessness prevention program as one excellent example of this collaboration, for which we're grateful for the support of both the county and the city. Thanks to $4 million of investment from both public and private sector funders, the program has prevented homelessness for 368 households with a 97% success rate, so remaining housed after the fact. In the first year, 65% of those assessed were San Jose City residents, and next year we're working to expand the program to prevent homelessness for 700 families. Thank you again for your collaboration.
Thanks, Bob. Welcome, Elisa. After Elisa is Joe Cafaro, Chris Moylan, Lisa Bauman, and Blair Beekman.
Good afternoon. I'm Elisa Ginsburg with the Behavioral Health Contractors Association. I want to thank everyone here, up here and over here, for bringing together all this information in such a thoughtful discussion. I want to take my time to focus on a critical issue that was mentioned and undercuts everything said here, which is workforce. We have an unprecedented workforce crisis in our county that Director Tully's referred to. The county has taken steps to increase the rates so that we can hopefully recruit and retain providers, but the pipeline is an area that we haven't been able to tackle yet. And among the high costs of living here and everything, at the same time, San Jose State has been reducing its social work program, which is one of the really important training programs. So I ask each of you as leaders in our community to impress upon San Jose State and other training programs that we need more behavioral health providers trained. They have a lot of pressure on them for STEM workforce, and they need to understand we also need behavioral health. Thank you.
Thank you very much. Welcome, Joe.
Thank you very much for having this forum. The Hospital Council of Northern California is an advocate association for all hospitals from Kern County to the Oregon border. I'm the regional vice president for the South Bay. Homeless community members have very complex medical and social needs in our transient. We see them all over our community. Every hospital within the county of Santa Clara treats all the homeless individuals. And I'd like to thank the county, because we've been such great partners with them and helping with this population. One of the highlights of our collaboration has been the Medical Respite Center, and also most recently, the collaboration for the youth facility. So I'd like to thank you for all your work and for bringing all the parties together. Thank you very much.
Welcome, Chris.
Thank you, Mr. Mayor, council members, supervisors. This is completely non-agenda. On behalf of Congressman Khanna, I have an announcement and a request. The announcement, the next town hall is tomorrow night, Milpitas High School, 7:30, and the one after that is Sunday, November 4th at Braley Elementary School in Sunnyvale. Since the Milpitas Town Hall is coming up, here's the request. We request that someone from the city, ideally someone from the mayor's staff, someone from the county, ideally someone from Supervisor Cortese's staff, start coming to the quarterly South Bay odor stakeholders meetings. There's always questions that come up that one of your staffers could answer, and we never have anyone there to answer it. The next one is January 17th. We just had one last week. It's only 4 times a year. Your staffer will get fed lunch. It would be a huge help to us. Thanks very much.
Thanks, Chris. Welcome.
My name is Lisa Bauman, and I'm here to advocate for my 27-year-old son. And I just am flabbergasted by all your programs that do nothing for young people who are happy, productive, who are law-abiding, but who suddenly have a mental health crisis. The laws here do nothing. The programs here do nothing. He was diagnosed on September 7th. Since that time, he hasn't been able to work. He's walked away from his apartment. I actually don't know where he is. He got in a car accident, lost his car. And this is a guy that was very successful up until a couple weeks ago. And I think that you don't understand what mental health is. I don't think you understand about medication, bipolar. It should be treated. It should not go past one episode, because that's when you talk about people who are homeless. And those are people who have struggled with it for years. So I implore you to learn about mental illness. Laura's Law was passed in 2002. 47 states have approved it. California's approved it, but Santa Clara County hasn't. It wouldn't help my son, and I understand it wouldn't help my son, but the whole problem is stigmatization.
Ms. Bauman, thank you.
Sorry.
Thank you. After Mr. Beekman is Mark Trout. Melody, I'm going to mispronounce your last name, so I'll just ask you to come up. Judy Young and Ron Davis.
Hi, everyone. Thank you for this meeting today. Assemblyperson Clara spoke here last week about the idea of data collection with mental health issues, and that's a new field that's growing, and he's fought really hard about this issue and has worked really hard. He's learned some hard lessons that I think places like San Francisco are going to really need, and I think we have to be on top of ourselves and really be ready to help places like San Francisco bring a progressive policy to this new data collection practices with mental health issues. Good luck on that issue. I wanted to mention the medication issue. Thank you for practicing in voluntary medication issues. I heard that's a problem here in Santa Clara. It sounds like you're trying to address it. Thank you. We don't have to be taking medicine to work on these issues. And just to mention, there's the county women's health issues, there's local women's Bill of Rights issues here in San Jose to help this process along. And work on your jail issues too, with mental health issues
Thank
too.
you.
Thank you.
Mayor, before I begin, can you call Sparky Harlan one more time? She may be losing her hearing, and I really want her to precede me.
Mr. Trout, it's time for us to hear from you.
Sparky, if you're out there, would you come forward, please?
Mr. Trout, you're addressing the council and the board.
Yes,
no one else.
I'm aware of that. Now, Sparky Harlan is head of the Bill Wilson Housing, and her so-called guests are required to take certain mind-altering drugs, and I gave her a book called Toxic Psychiatry by Peter Breggin. And Peter Breggin suggests that since he has done huge amounts of studies on these mind-altering drugs that are forced upon people that have so-called mental illness, and since they exacerbate the problem, that we should slowly, get them off these drugs, okay, because they don't help, they make the problem worse. And no one has addressed this. This is a very important thing. Okay?
Thank you, Mr. Trapp. Welcome.
Good afternoon. I am Melody Masaniai, and I am a voter and business operator in Council District 3 and Supervisorial District 2. I just want to mention today about the Board of Supervisors agenda item number 27 from the previous Board of Supervisors meeting. I believe that the Truth Act requires a 30-day public notice, and if there was 30 days in the public notice, you can't tell by me. Number one. Number two, there are a number of items that are suggested in the Truth Act that were not covered in that meeting. They are the requirements when ICE is given access to the data or the person. They are also the instruments with which approval was given to ICE to access the inmate or the records. These were not covered. I hope that as County Council works with the community people, that this will become part of the agenda on December 3rd.
Thank you very much. After Ms. Young and Mr. Davis, Pablo Guinness and Amanda Clifford. Welcome.
I'm Judy Young. I'm with the South Bay Progressive Alliance, and we're here today to introduce the topic of public banking. A public bank is a bank that's owned by a public entity, a city, county, state, could be a school district as well. The reason public banks are important is, well, mostly twofold. Interest rates charged by public banks that exist are half the interest rates of Wall Street banks. The other major point is that interest is recaptured by the public bank and it's recirculated in the local economy, which really helps make the local economy more vibrant and stable. Public banks can save cities and counties millions of dollars in fees and billions of dollars in interest every year. Let's see.
Thank you, ma'am.
That's it.
Thank you very much. Mr. Davis?
I'm also with the South Bay Progressive Alliance, and I should make the link here. Public banks, one of their main features is the ability to make loans for low-income housing, affordable housing and public housing and whatnot. So there's a connection there between the topic today and public banking. In the last couple of months, I visited twice with the Consumer Affairs Commission to promote the idea of taking up the issue of public bank in Santa Clara County. One of the first steps in doing that is to have a feasibility study that would involve a needs assessment, financial analysis, and a legal analysis for the feasibility of such a bank. These types of studies have been undertaken in Oakland, where their feasibility study has actually just been completed. And there's a feasibility study being done by San Francisco. And
Thank you,
it's
sir.
in process. It'll be completed by the end of the year, and there'll be a report on that.
Thank you, sir.
Okay. We'd like to present.
Thank you.
Hello. Hello, I'm Pablo Guenes. I live in District 3, and I'm here to ask you to fix the apartment rent ordinance. This year, an exception was added for voucher units and basically exempting them from the standard rate. In my particular case, I had been a tenant in a rent-controlled unit for 8 years. A new owner came in. In the meantime, in the last year, I had to accept help via voucher, falling on hard times. The owner invoked this rule in order to effect a 45% rent increase. So for the time being, I'm shielded by the voucher, but if I want to get a job and so-called graduate from the program, well, I can't really do that. That's a barrier to getting off of public assistance because now I would face a 45% increase instead of the 5%.
Thank you, sir. Thank you. Ms. Clifford, you'll be our last speaker.
Good afternoon. I'm speaking on behalf of Sparky Harlan, CEO of Bill Wilson Center. My name is Amanda Clifford, and I am the Policy and Advocacy Specialist for Bill Wilson Center. The county's Behavioral Health Department funds a number of Bill Wilson Center services in downtown San Jose, including our drop-in center, our street outreach team, our LGBTQ youth services, our respite, our transition age youth behavioral health services, and our cold weather shelter. With all of our behavioral health funded services, we are able to serve about 1,000 young people a year. Bill Wilson Center would also like to thank the City of San Jose for their contributions to Bill Wilson Center's drop-in center, including rehab dollars and funding provided by the Mayor's Gang Prevention Task Force. Finally, I would like to end by saying Bill Wilson Center will be participating in the point-in-time count this year, and USC will be conducting its Homeless Youth Risk and Resiliency Survey in downtown San Jose. Thank you so much.
Thank you, Amanda, and thank you for your work. Supervisor Chavez?
Thank you. I wanted to make an announcement under item 7, and I'm going to be passing a letter down to my colleagues. And this is a letter from myself, Vice Mayor Carrasco, and Council Member Sylvia Arenas. And what you have in front of you is an attempt by us to really try to address a comprehensive way of addressing sexual assault in our community. And this has really been inspired by both the Me Too movement, the Time's Up movement, and most recently by Dr. Christine Blasey Ford's just really bravery at having this conversation publicly. So it's our intent to request a joint meeting between the county's Children, Seniors, and Families Committee and the city's Public Safety and Finance Committee to bring to the board and the City Council policy and budget recommendations that we think could transform the preventative work of services for victims. There is, and we know, an inherent gender bias associated with the crime of sexual assault and how we as a country have approached this problem historically. 91% of victims of rape and sexual assault are women and girls, and there is a 99% chance that the perpetrator will get away with the crime in this country. I'm not talking about our county, by the way. I don't want any of our folks to say, well, we don't, because we do things differently here. But what we want to do is change the social norms and social costs that have enabled really persistent statistics and social norms to impact the victims. And one of our real concerns is people not, and women and girls and children not being able to come forward and report the crime. So what we're asking, and really we wanted to make this informative for all of our colleagues, but also to get your thoughts about how we can address this and talk to any of us who are on these committees. And at a future time, perhaps when we meet again, we'll have a response and some strategies that we can share with both of our respective boards.
Thank you, Supervisor. And we'll certainly take that up offline. The meeting's adjourned.